All right. Welcome back to NeuroClarity, where complex neurology concepts meet clinical clarity, one brainwave at a time. Today, we are diving into three high-stakes clinical scenarios, from devastating strokes to a reversible but alarming syndrome, all drawn from Ching and Cheng's comprehensive review of clinical neurology. We are going to be doing questions 10 through 12, so grab your coffee or white coat, whichever you prefer, and let's dissect some neurocritical decisions. Question 10. A 48-year-old man is found comatose after not being seen for at least 2 days. He requires endotracheal intubation on the way to the hospital and is admitted to the neurocritical care unit. His CT scan is shown in figure 3.4. Let us take a look at the CT. Which of the following is correct regarding the treatment of this patient? A. Endovascular reperfusion therapy is the next step in treatment. B. Anticoagulation with intravenous heparin is indicated to prevent expansion of the stroke. C. Hemicraniectomy improves survival and intraventricular catheter should be placed. And E. Dexamethasone should be started at a dose of 4 mg intravenously every 6 hours. What do you think? Before we dive into the choices, let's talk about what we are seeing. This non-contrasticity of the brain shows a diffuse hypodense area in the right cerebral hemisphere, extending across the frontal, parietal, and temporal lobes. This is classic for a complex right MCA territory, in fact. But that's not all. Note the effacement of the cortical sulci, the loss of gray-white matter differentiation, and most alarmingly, the midline shift to the left, which indicates rising intracranial pressure from massive cytotoxic edema. The right lateral ventricle is compressed and the falx cerebri bows towards the opposite side. This is what we call malignant cerebral infarction, and in fact so extensive that it's no longer a stroke, it is space-occupying lesion. It is a feared neurological emergency characterized by complete infarction of an MCA territory, massive edema, and brain shift. The name malignant isn't hyperbole. Conservative therapy in such cases has a high mortality rate of up to 80%. So, endovascular therapy, well, not anymore. The infarction is complete, there is no penumbra left to salvage, and reperfusion now increases the risk of hemorrhagic transformation. Heparin, that's a hard no. There is no indication for anticoagulation in large territorial strokes without an embolic source, and it may even cause bleeding. How about intraventricular catheter? Well, there is no hydrocephalus or intraventricular hemorrhage. Dexamethasone? Corticosteroids don't help with ischemic cerebral edema. In fact, they may even worsen the outcome. Hemicraniectomy, on the other hand, especially when it's done within 48 hours, can be life-saving. The goal is to relieve the intracranial pressure and prevent herniation. Clinical peril. The younger the patient, the higher the chance of malignant edema. Watch out for early hypodensity greater than 50% MCA territory, NHISS score of 15, and significant midline shift. Those are indications that this patient may have malignant edema. So, our correct answer is C. Early hemicraniectomy improves survival. Next question. Question 11. A 45-year-old patient with history of hypertension and end-stage renal disease on hemodialysis presents with altered mental status and a blood pressure of 210/118 millimeters of mercury. While in the emergency room, he has a generalized tonic-clonic seizure and requires endotracheal intubation. He is then admitted to the neurocritical care unit. His brain MRI is shown in figure 3.5. Let us take a look at it. Which of the following is the most likely diagnosis? A. Embolic strokes. B. Acute disseminated encephalomyelitis. C. Intracerebral hemorrhage. D. Viral encephalitis. And E. Posterior reversible encephalopathy syndrome. What do you think? Let us take a look at our MRI again. Now, this is a FLAIR sequence. FLAIR stands for Fluid Attenuated Inversion Recovery. And what grabs your attention? Well, We see bilateral patchy areas of hyperdensities in the parieto-occipital lobes, and these are symmetrical and predominantly cortical subcortical in nature, sparing the deep green nuclei. Unlike ischemic stroke, these lesions are not restricted to a single vascular territory and they do not follow arterial boundaries, and that is your first clue. These changes here are consistent with something we call visogenic edema and not cytotoxic edema. And why is that? That's because the underlying blood-brain barrier is leaky due to disruption of autoregulation and not due to dead brain tissue. This is PRES, Posterior Reversible Encephalopathy Syndrome. In PRES, the posterior circulation, which perfuses the occipital lobe, is the most vulnerable to blood pressure fluctuations due to relatively less sympathetic innervation, and that is why edema hits the back first. PRES indeed is a clinical radiologic syndrome and it is usually reversible. It is characterized by headaches, seizures, altered mental status, visual disturbances like cortical blindness. The MRI findings here, like we said, shows visogenic edema in the posterior circulation territories, especially the occipital and the parietal lobes. Sometimes you may actually have involvement of the frontal lobe, the brainstem, and even the cerebellum. What are the risk factors for PRES? Well, severe hypertension, renal failure, immunosuppressive therapy like cyclosporine and tacrolimus, chemotherapy, eclampsia or preeclampsia, and sepsis. The pathophysiology is not fully known, but it is tied to disruption of the cerebral autoregulation, especially in the posterior circulation, which leads to hyperperfusion, endothelial dysfunction, and visogenic edema. How do we manage? 1. Rapid blood pressure control, although you have to avoid overcorrection. ICU support is very essential and you need to withdraw the offending agents. For example, if there's a chemo or an immunosuppressant, you need to stop that. Our next question still dwells on this case, and that's question 12. Which of the following is incorrect regarding the condition of the patient depicted in question 11? A. Immunosuppressive therapies have been implicated in the etiology of this condition. B. There is an association between cancer chemotherapy and this condition. C. Hyperlipidemia is intimately linked with this condition. D. This condition can be seen in association with eclampsia. And E. Hypertensive encephalopathy is intimately linked with this condition. From what we've said, what do you think? The correct answer is C. Hyperlipidemia is intimately linked with this condition. That is not correct. Unlike other vascular pathologies, hyperlipidemia has not been linked to PRES. Let us fact check the others. Immunosuppressive like cyclosporine and tacrolimus, well, you see that they are big corporates, so they are highly involved. Chemotherapy, particularly with agents like bevacizumab, has a very strong association. Eclampsia, well, that's the classic PRES territory. And in hypertensive encephalopathy, PRES is often seen as part of that spectrum. Our key takeaway: PRES is all about endothelial injury plus field autoregulation. It is not a cholesterol problem, it is a pressure and a perfusion problem. Let's do a recap and bring all this together. First, a large MCA infarct with midline shift needs early hemicraniectomy, not anticoagulation or steroids. 2. A patient with seizures, renal disease, and posterior brain edema, think PRES, not embolic stroke or encephalitis. And remember, hyperlipidemia is not associated with PRES, and you need to keep your differentials sharp and your mechanisms even sharper. And that wraps up another high-yield episode of NeuroClarity. Whether you're preparing for the rounds, the boards, or just trying to stay sharp, remember, clarity in neurology comes from pattern recognition, pathophysiologic understanding, and knowing what to leave out of the picture. Until next time, keep your minds open and stay clear. Bye for now.